I'd like to call the Health and Human Services and Aging Committee to order. May I have a roll call, please?
Calling the roll. Sorry. Calling the roll, Ms. Conwell.
Here.
Mr. Hauser. Here. Ms. Brown. Ms. Brown is absent at the moment. Ms. Baker. Here. Mr. Miller.
Here.
We have a quorum.
All right. Anyone signed in, Madam Clerk, for public comment related to the agenda?
Yes, Reverend Pinkney Butts.
All right.
Jesus Christ, we need your spirit right now to come through this place, to address these laws. You said that the letter is for death, but the spirit is for life. And we need the letter and the spirit to match to heal these lives, Jesus. Resolution, I'm Reverend Pamela Pinkney Butts, and I'm reserving all of my rights, human, civil, constitution, and all the others, international rights at this time. And I will be coming back at non-agenda items. And I am currently seeking the United States House of Representatives seats for the 11th District for the state of Ohio. And I'm very concerned about this Department of Health and Human Services, locally and nationally and internationally, because another shooting just took place in a school, and another mother, her children didn't come home from school. And you're writing these resolutions, number 63, 64, 65, and 66, resolution 2018. And you currently put my grandchildren in danger on February the 21st of this year. And you put my grandchildren in a home where my daughter's being beat up by a man on a regular basis. And I've been coming to you all for years. And I want to know where this money is that's going to the YMCA, domestic relations court, juvenile court, child support, and at-risk children, when you have done it to not only my grandchildren, but my children and to me. And I want some accountability for this money. And I want you to stop playing games and dodging my phone calls. You have my grandchildren in danger right now and my daughter. And I'm holding you accountable. Because another child should not be going to school with a gun. You took prayer out of the school and you replaced it with pistols. You took prayer out of school and you took pens and papers out of school and you replaced it with pistols, gun tasers and metal detectors. And when children go to school, they see that. And you're giving them a mixed message. And then you have people coming here and stand behind me with guns and officers. You don't have it right now because I've been talking about it. Your racism is ridiculous, too. My grandbabies and your caseworker, Sierra Watley and Yolanda Lewis, had the nerve to tell my daughter that if I have my grandchildren to call Amber Alert and have me arrested after your caseworkers told me to keep my grandchildren and told me they didn't care if my daughter was homeless the rest of her life or not, they would never give me anything for my grandbabies. What's going on around here? Who's getting the money? Because I'm not. I'm being denied medical care. I don't care about your bail. I care about my health and my babies.
Anyone else?
Yes, Ms. Clayton.
Good afternoon.
Good afternoon.
Good afternoon.
Good afternoon. I am standing here on behalf of the Euclid Hillcrest Collaborative of the YMCA of Greater Cleveland. And obviously, it's ironic that a year ago, I was standing, asked by Mr. Math to talk to the benefit of the collaborative. But today, I'm here in a different vein. We are simply here to ask two very specific questions. The transition plan that we have yet to be afforded according to the current contract that we are currently in. Once an actual letter of not moving forward or the decision to not move forward, we're supposed to be given 30 days. We have very active families that we don't feel that this is enough time to properly or fairly transition them out. We are the fiscal agent for our foster families, and we need time to close those funds out. We have community events, and we are also partners with entities such as Shoes and Clothes for Kids that we have scheduled dates and times. Obviously, we can cancel some moving forward, but we're just asking that the county would support us in the 13-year relationship, that stellar relationship we've had, that we would be able to get some information. And also, the second question is, we submitted a letter of protest and appeal. And again, just something more final so that I can relay that to my executive so that we can know how to move forward with our families as our first focus. Thank you.
Thank you. Anyone else, Madam Clerk?
Yes, Ms. Lou?
Good afternoon.
Good
Good afternoon.
I'm here on behalf of myself and lots of people in the past and present been staying at the shelter, actually called Norma Hale on Payne Avenue. I have been coming here for a while. I have stated clearly the treatment we have received when you come into the shelter. Welcome to inhumane society. The reason to push me to come up here, because even we have to struggle with clean drinking water. I'm not here to asking for anything fancy or very advanced, because we know county has been losing populations, losing tax revenues. Even county council has been working on lots of things, try to take care of everybody, but still, we don't have enough money for everything. However, the important thing is, county did hear me and did recognize the importance to increase funding to offer proper service, because this service is on the same principle just like any others. From taxpayers' money, collectively, county will govern all the helpful services to help all the residents in need. But here is the funny thing. Last Thursday, when we had OHS advisory meeting, I attended that meeting. In this meeting, we mentioned another issue. It was about homeless, but it's family category. When I asked a question that if they could have one more caseworker to help people in the overflow area, I was barked at by the person representing Frontline Service, the current service provider for this Norma Hale for a long time. She asked me for my checkbook. Sure, I can offer mine, but that will be just rubber checks. From a service provider monopolizing all the fundings and housing resources, asking a homeless individual for a checkbook. I think it's pretty ironic. Sure, some people did not understand the details of it. They actually left. But I still want to thank County Council's help to increase the dollar amount, which probably will help us a little bit, but still. YWCA did not realize the importance of overflow because they were never told, even they have been working with Frontline Service and OHS. Thank you very much.
Thank you. Anyone else?
No, no one else has signed in.
All right, I'd like the record reflect that Councilwoman Brown is in attendance. Approval of the minutes from the March 7th, 2018. Can I have a motion to approve?
Second.
Moved and seconded. All in favor, say aye. Aye. Minutes are approved for the March 7th meeting. We have several matters referred to us today. Madam Clerk, if you could please read the first item into the record.
Resolution number 2018-0063, making awards on requisition number 40883 to various providers for community-based services to support at-risk children and families in Cuyahoga County for the period 4/1/2018 to 3/31/2019.
Good afternoon, Bob.
Good afternoon. Bob Math with the Department of Health and Human Services on behalf of the Division of Children and Family Services. We're bringing forward this recommendation to award contracts to these 9 organizations based on an RFP that we issued back in September of 17. These services are really to provide community-based support services which address the needs of families that are currently involved in a child welfare system or families that are at risk of entering into the child welfare system, and then those youth aging out of foster care. This model of community-based services was emanated from a philosophy established by the Annie E. Casey Foundation that called for a partnership between child welfare agencies and the communities where at-risk children and families lived. It was acknowledged that the work of protecting children needed to be a group effort. Communities did not want their children removed, and DCFS, the Division of Children and Family Services, fundamentally believed that children belonged with their families as long as it was safe for them to do so. These organizations provide a wide range of services that include case management, service coordination, emergency assistance, supervised family visitations, and independent living skills and training for youth aging out of the foster care system. These services are provided in order to meet several key objectives of the model. One is to improve family functioning, to strengthen family supports and access to community-based services, reduce placement moves of children in the community, expedite reunification of families that are involved with the Division of Children and Family Services, increase housing stability for newly rehoused families and youth aging out of foster care, increase enrollment into pre-kindergarten programs for eligible children, and increase independent living skills for youth that are also aging out of the foster care system. In 2017, through these collaboratives, over 3,500 families were served and provided these wide range of services. Council Chair Conwell asked me the other day if I could talk a little about just the RFP process and the review process. So I'd like to just take a few minutes and share how that process unfolded. We received 12 responses in response to the RFP that we issued. We had over 30 reviewers reviewing the proposals. Reviewers came from the Division of Contract Administration and Performance, which is the department that I direct, staff from Department of Children and Family Services, some staff from the Communications Department here at the county, and staff from on the workforce side. We developed review teams. Each review team read 3 proposals. We had 4 reviewers on each team. We had 8 teams, and so what we did is we had multiple teams reading the same proposals. So we had a whole set of eyes, a number of set of eyes reviewing each of the responses. The scoring and evaluation mirrored exactly what was contained in the RFP. After the review teams reviewed all the responses, each agency was invited to discuss their proposal, provide clarification, and respond to questions that may have been that arose during the review process by some of the reviewers. And based upon the team's evaluations, the follow-up meetings, and the recommendations were made as presented before you. Also, yesterday, Council Chair Conwell asked me to talk about the terms and length of the contract. These contracts are scheduled to begin April 1st for 1 year, for a 12-month period from April 1st, 2018 through March 31st of 2019. We always build in 2 option years, 1 year at a time. It's all predicated on agency performance, organization's performance, agency priorities, and funding availability. But then, Council Chair Conwell asked if we, is there any opportunity to expand that RFP if we need to bring in additional providers? And I said, really, it's all predicated on the demand for the services. If we see that in the course of the year, the demand far outweighs our capacity of these organizations, it always gives us the opportunity to reissue or issue another RFP for the subsequent year. I also want to add that these contracts are very outcome-driven. Each of the contracts has strict performance outcomes that we expect them to achieve, and there are 4 outcomes that are the same in each and every contract that we expect them to achieve. And then some of the respondents had additional outcomes. The outcomes that we included in the contract were outcomes that the organizations had full control over, all right, that they can be held accountable for. In other words, engagement, there was, self-sufficiency, so when families are, were moving into new homes or youth aging out of foster care, that they had a stable home, they had an income, they had employment. There was a state that they're moving into a safe and stable environment, and they all use the same tool to measure family functioning, which is an assessment tool that has 18 different domains that we measure them on. And then satisfaction. We want to make sure that anybody in receipt of these services are satisfied with the service they receive. So these are the 4 performance outcomes that are in each and every contract. Some of the proposals have some additional outcomes that they felt they could achieve. Some will regard family stability, family reunification, effective parenting skills. Those are some, depending on the service those organizations were offering, there were some additional outcomes. So that's, those are the outcomes that we can hold them accountable for. So I would be happy to entertain questions. We have some leadership from Department of Children and Family Services here, and a number of our, partners in this, some of the family collaboratives. If you have some additional questions, they would be happy to entertain them.
Any questions from the committee? Councilwoman Brown?
Thank you, Madam Chair. How you doing?
I'm well.
Okay, so how long were these contracts in existence prior to the new RFP?
Some of these, initially I'm told that some of these, there were 14 collaboratives at one point in time, I understand, and they go back over 20 some odd years.
20 odd years.
Yeah.
All right.
Some of them were added during the course of that 20-year period. I don't know the exact dates of how each one was, how long each one was in, conducting business.
How was the resources determined prior to this new RFP process? How were they determined to be allocated to those that were previously a part of the collapse?
Councilwoman Brown, through the chair, the respondents indicated in their proposals, how many families you're expected to serve, and the budget, the figures they budgeted to serve those number of families. So we sat down with each of the providers, looked at how many families are to serve, how many staff they need to serve those, what kind of resources they were going to provide. So the contracts, the dollar amount in the contracts, well, all very similar if you look at them. They varied with, staff, rent is different at different places, salaries are, vary from one provider to another. When you look at the dollar amount in the agenda, you'll see there's some that are, higher than others. So if you look at Catholic Charities, which is $737,000, they have two centers that are providing services at Martin de Porres and Fatima Family Center. All right. In Murtis Taylor, you see it's $1 million. They're running 3 sites. One in the Union Kinsman area, one in the Garfield Heights area, and one in East Cleveland. So when you look at when it gets down to, each of them receive fairly similar amounts. They're all in the area of $450,000. Some of them also have multiple sites, so that's why those contracts appear larger.
Okay, so that is helpful. So one of the things that I wanted to know is, historically and with the current contract, are administrative costs included in these contracts? You kind of touched on it a little bit,
Right.
but
Some of the providers, they have what they call an indirect cost.
Okay.
Not all of them included indirect costs. That was their choice. We understand that to operate a program, that there are administrative costs that are associated with legal fees and HR fees and so on, and accounting fees and so on. Some of the organizations charge us nothing for indirect costs. Those that did, they were all very modest. They were all within around the 10% range, which is in our world very, very modest.
okay, and I know you touched on the outcome-driven components that would be used to help them measure. This is something that was new to the RFP, or was this?
Councilwoman Brown, there's always been, these are very specific ones we've included in the contract. I think, and some of the collaborative partners can probably address some of the outcomes they've achieved individually. This time we included in the contracts. I think all of them have achieved outcomes. They haven't necessarily reported them in a particular format. We've developed monitoring templates and performance reports, so there's consistency now among all the organizations.
Okay, that's good to know. So now there is some consistency,
Yes.
but prior to that, there may have been some inconsistencies. I can
Well, they were all using the same database, you know, but, you know, in terms of, you know, providing that information and collecting it all was a challenge, I think.
Okay, and then my last, if I may, Chairwoman, is accessibility and accountability. As you kind of touched on, there were some inconsistencies there. So, how much consideration is given to accessibility for the communities where you have a densely populated area? Is that factored into the proposal at all?
Yes, you know, Councilwoman Brown, through the chair, we do a matrix with all the zip codes, you know, to ensure that as many neighborhoods as possible can be served. You know, there was in the past, there was always some overlap, so you know, so some of those zip codes where it was densely populated, as you suggest, that sometimes there were more than one collaborative one organization that was serving those families. So we've done a matrix to ensure that the best we could, you know, with the funds that are allocated for this model, you know, to cover as many areas. I think that, you know, an area that, you know, if a family comes from a zip code that's not really closely aligned with another provider, there's not one provider that will say we won't serve that family. You know, we can provide them the transportation, do whatever it takes to get that family there.
And then my apologies. With that, when this is a referral-based program, am I correct? The collabs get their clients via referral.
Through Department of Children and Family Services.
So the funds that correlate with the dollars here are not where someone would typically maybe walk off of the street and say, hey, I need to, one of the things you touched on was employment. I need help with employment. That's not something.
No, Councilwoman Brown, we do include that in the budget. I mean, so it's not, you know, we understand that, you know, the majority of the families they serve are referred by the Department of Children and Family Services. To your point, there are families that walk in because they're familiar with the organization, they're in the neighborhoods, they need help. So there is money in the budget to accommodate those.
Okay, and I thought that would be my last question, Chairwoman, but I'm sorry. Relative to that, since it is referral based, I understand that there may have been an agency that were still receiving referrals. Is there some type of ramp down period or transition for any of the collaboratives that were previously funded that may not be funded?
Yeah.
Okay.
Councilwoman Brown, and we've been working on that for the past several weeks with, it's DCFS has identified those families that are being served by those other entities, and they're reaching out to them. That's our highest importance, to make sure that the transition is as smooth as possible. You know, so they are reaching out to these families to assure them that they will be served, and these are the different providers that will be serving them going forward. So that plan is it's in place as we speak.
Okay, no, not you yet. You after Miller. Miller, then Hauser. I just was seeing if she was done.
Madam Chair, Mr. Math, if after a year you decide you want to extend this contract,
Share that with him.
is it extended all or nothing for all of the providers, or you can pick and choose and say you're going to extend this one, but you're not going to extend that one?
Councilor Miller, through the chair, we have that, we can exercise that option. And it's happened in the past, and we'll look at, during the course of the year, we monitor their performance. They have to submit monthly reports and quarterly reports. So if we see that for whatever reason, potentially there's an organization that is underperforming, we don't expect that to be the case, to be perfectly candid. But if there are, we can readjust those dollars going forward. So there's no kind of entitlement, no guarantee that if they receive X number of dollars this year, they receive the next amount of dollars. Again, it's demand. You know, if in some neighborhoods demand is lessened, you know, then we will reflect that going forward.
And can you just name the major kinds of services that are provided?
The major service, it's case management. So when families are referred, they make sure they follow up. They stay engaged with these families. They follow up with them. They provide service coordination. So if they're linked to other services within the community, they will provide that kind of linkage, follow up. So if they have to receive, AOD treatment or mental health treatment, they refer them to an appropriate agency. They will provide that service coordination. They have money in the budget for emergency assistance. So if a family walks in the door and they say, geez, my rent is due and I don't have it today, I'm waiting for my next paycheck, or utility assistance, or they're short on food or baby food or diapers, they have the ability to issue emergency assistance on the spot, which is one of the core services. They do provide supervised family visitations. So families that that have children in placement. Oftentimes, the visitations need to occur, non-working hours. So many of those supervised visitations occur in the evening or on the weekends. And the providers their staff will, in addition to the DCFS staff, will be there to family visitations to support that. And then they'll provide what we so-called independent living skills or training to those youth that are aging out of foster care. So it's money management, financial management. They'll help them with, housing, employment opportunities, those kinds of things. So those are sort of the core activities.
And are most of the families foster families?
Councilman Miller, through the chair, I would probably have to defer to Jackie McCrae's Deputy Director, DCFS. I believe that probably, the last figures I looked at, probably about 75% were DCFS cases versus, walk-ins, if you will, in the neighborhood. If that seems like a fair assessment. Very fair. So last year, they served, somewhere in the neighborhood about 3,500 families. So whatever that 75% is, were people that are referred by DCFS. And the balance would be families that are in the neighborhoods that walk into these organizations because they need help.
And
Introduce yourself.
good afternoon. My name is Jacqueline McCrae. I'm one of the deputy directors with the Division of Children and Family Services. So in response to your question, Mr. Miller, most of the families served are families that are not foster families, although foster families are included in the population that's served. Primarily, it's families that are in the community that are at risk of becoming involved with DCFS or currently involved with DCFS.
Okay, and Madam Chair, to Ms. Ashley, if you could add my name on this item, I would appreciate it. Thank you.
Officer here.
Through the chair to Mr. Mav, we spoke and you answered most of my questions sufficiently. I was just wondering, since some of the objectives have changed, we even had a new HHS director in Tom Purcell who's not with us anymore. Was any of that taken into factor when reviewing the RFP?
Councilman Hauser, through the chair. Not really. I mean, the RFP was crafted while he was still here. When we issued it back in September, and we worked with DCFS leadership to determine kind of what we want to do going forward. I don't think, the model was, it was not a local model that we we followed. It was a national model that was evidence-based. So we didn't really make that had no bearing on, on the process going forward, his departure. If that answers your question, got it right.
Chair, most questions have been answered, and thank you for your work out there. It's very much needed, and we're glad that you're there giving the support of those that are in need. The couple questions I guess I haven't heard yet is, I know there's 3,500 families. Well, how many children is that? On the average, how many children are you actually servicing, taking the custodial piece out of it? Are we talking about maybe 3 to a family, 1 to are we 7,000 children, double the amount if you're 3,500 families? How many children are we actually on an average servicing?
We can most definitely get some more specific numbers, but on average, the majority of families that we serve have an average of 3 children, so 2.53 children for the most part.
Thank you, and that's fine. The second question I had is, if you find that you're in an environment where it's beyond what you can do to help, say all the different outcomes that you hope to have, or all the different assessments that you try to achieve, if you're not successful, if it can't be successful, what safeguard do you have for those children to make sure that they are taken care of? if it can't be done within the circumstances that you're walking into?
From the perspective of the Division of Children and Family Services, when a child cannot be safely cared for in their home, we look at other options, and those options include DCFS with the court's approval, assuming custody of that child until safety issues that led to that child being brought into our care are mitigated. And that is part of what the neighborhood community partners provide, is once a child may be in our custody, continuing to work with that family in order to facilitate reunification.
Thank you for that. The range of what you service, I would imagine, is broad. Whether those families have children with disabilities, of course, those that are in poverty, perhaps there's just extenuating circumstances within the family structure. Do you, for the most part, walking into those families, are able to help most situations that you encounter?
Well, I can speak from the perspective of the division. And in terms of children and family services, once a family is brought to our attention, we investigate what is leading to them coming to our attention. And we do, serve families that have complex issues and complex needs. The majority of the families we're able to serve within their home and keep the family intact. There's a smaller percentage that unfortunately cannot be safely cared for at that point in time, and that we assume custody of, with goals of working towards reunification when that's safely possible.
Did you want to add?
Councilwoman Baker, through the chair. Councilwoman Baker, through the chair. We have some, folks from the organizations. If you really want to get a kind of a firsthand, they can tell you when a family walks in, kind of really what that looks like. What kind of circumstance they deal with, what kind of services. So we have some representatives from the organization. If you're interested from hearing from them, they can surely give you really a firsthand description of what transpires when a family walks into their office. If you would like to, if you're interested.
It's up to the committee members if they want to hear it.
We could take up committee time, or we can do it offline, whatever is good for the chair.
So we don't need to do that today, I don't think. Unless someone has a particular interest they want to hear of the great work that our collabs do.
Yes, and thank you again for the work that you do out there. It is important, it's needed, and I know you're in the trenches of making families whole. Appreciate it.
All right, any further questions from the committee? All right, hearing none, I thank you, Ms. McCray. I think Levine would like to talk to you over there, so we could schedule something offline. And just want to say to the committee, we are not prepared. We're going to hold this for a week, this contract, so there's some further investigation I'd like to do, so we're going to hold it, and we'll move to the next item. And Mr. Math is aware of that.
Thank you.
Madam Clerk, can you read the next item into the record, please?
Resolution number 2018-0064, making an award on requisition number 40102 to Young Women's Christian Association of Greater Cleveland in the amount not to exceed $1,936,749 for operation and case management services for the Nirma Hare Women's Shelter located at 2227 Payne Avenue, Cleveland, for the period 5/1/2018 to December 31st, 2018.
Right. Who is here to speak to this?
Good afternoon. I had asked Bob Math to describe the RFP process for the committee.
Okay,
So,
we can give him a few.
and then I was going to provide some information about the contract. So,
Good afternoon, Bob Math. The RFP process is terribly similar to what I described just a minute ago. We did issue that RFP, and I don't have the date in front of me, Ruth, when we issued it. But we did issue an RFP. You know, we sent it out to a variety of different organizations, and we used, of course, the county's buy-speed list to ensure that as many organizations potentially could respond to this RFP are aware of it. When we issued the RFP, we, of course, as part of that process, we have what we so-called pre-proposal conference. So people that are interested in responding can come and ask questions about the RFP, ask for clarification about the RFP, what's contained in it, and all the kind of accompanying information that needs to be included in the RFP. When the RFP closed, there was only one response to this RFP. That was from the YWCA. But we conducted the RFP process, as I just shared with you just a minute ago about our review process for the community-based services. That same process occurs. Clearly, we didn't need 30 reviewers and 8 review teams to review one response. But we had a number of reviewers that came from a variety of different entities within the county to review it. Also, as part of that process, we brought the Y in for give an opportunity for clarification for questions that surfaced during the review process, and then we went forward and made the recommendation. I do want to say that generally at least personally and professionally, we don't make recommendations by default. So just because we only had one respondent doesn't necessarily mean that we guarantee that person's going to receive the contract. So if the response didn't meet some of the qualifications that we were seeking, and during the meeting we had with the Y, if they couldn't come up with the response to the questions that were surfaced, then we'd go back to the drawing board and reissue an RFP. And we've done that. Some of you may recall we've done that not on many occasions, but on several occasions we've had to reissue RFPs. So we don't make a recommendation by default. But I think the Y responded with a very credible our proposal, and based upon the budget and the allocation, there was obviously the lengthy negotiations, which I'm sure some of you are very familiar with that. But we got to the point where we thought that we could move forward with our recommendation. So so the review process, the RFP process is, again, we like to develop some consistency. So whenever we issue an RFP, it's the same process that we go through, regardless if it's for one vendor or multiple vendors, whether the contract's for $1 or for it's millions of dollars, that we conduct the same review process.
Ruth Gillette, Office of Homeless Services. I don't know if council has any questions about the RFP process. I could go into details about the contract if you'd like.
I don't, not on the contracting part.
Okay, great. Thank you. Thanks, Bob. I provided a handout for each of you that kind of summarizes the contract details. This is a contract for 8 months of service with the option to renew for 2 12-month periods. So that would take it through 12/31/20. As Bob had indicated earlier, there'll be contract monitoring that would inform the continuation of the contracts beyond the 12-month period. I've highlighted for you the proposed staffing pattern at the shelter. Would like to point out that there are several new positions through this contract, including the front desk navigator, which was kind of a greeter position during the day. The number of case managers through this new contract is more than doubled. The number of advocates or shelter monitors is roughly the same, deployed through a 24/7 timeframe. The volunteer coordinator is a new position, as is the compliance manager. The service model is focused on a client service approach. I believe that the YWCA is looking to organize the shelter population based perhaps on similar characteristics, much like Lutheran Metropolitan Ministries currently does at 2100 Lakeside, where groups who may be more interested in pursuing services would be organized or, for example, if some groups are more focused on employment. But in general, all services will be offered to all clients particularly with an emphasis on rapid exit and housing. All clients will be linked to services as appropriate, either on-site or off-site. Efforts will be made to enroll clients in benefits that they're eligible for, to link clients with employment. And would also, the whole model will be informed through client input received through resident meetings. All the staff, including contracted staff like the security officers, et cetera, will be required to have training in conflict resolution, trauma-informed care, racial justice, engagement strategies, so that the culture of the environment will be consistent throughout all staff. And as I said, the monitoring will be done monthly and also on a quarterly basis by Bob Math's staff. We'll be looking at the number of persons served, the number of exits, the number of positive exits, the number of grievances filed, the resolution of those grievances, and the number of mediations. We consider mediation a positive thing because it indicates that there's efforts being made to resolve differences as opposed to discharge clients. The building will continue to be managed by Eden through resources provided through Health and Human Services levy. Funding for that contract was also increased. So we are looking to make sure that the building is safe and clean and appropriately managed. I'm happy to answer questions. Teresa Sanders, who is the Chief Program Officer for the YWCA, is also here and is, happy to answer any other questions.
Director, one of my issues was some of the policies that were with Frontline. Have you had a discussion with the YWCA in terms of what, or have they had an opportunity to look at some of the old policies that Frontline had for the women's shelter? And are they going to have any new ones added to it, or has there been any discussion where they're made aware of that?
To the chair. So, as you are aware, Council approved a transition contract, and during this period, which started February 1st till May 1st, we're working very closely with the YWCA, and one of the areas that we're focusing on is their written policies and practices. And I can give you a list of that. We've been meeting every other week. We're meeting tomorrow morning. And so the short answer is I haven't seen the policies yet, but we will be looking at those policies prior to May 1st and making sure that they have a policy and that it seems to be appropriate for the situations that they're going to be dealing with. Would you like more information from Teresa Sanders on that right now?
Yes, because I would have thought that would have been in place before we move forward with the funding.
Right, to the chair, I think because I haven't seen them doesn't mean that they're not in progress. So,
Okay.
if you want to introduce yourself there.
Good afternoon. My name is Teresa Sanders. I'm the Chief Program Officer at the YWCA Greater Cleveland. And the policies are developed. They're in draft form. We're going to present them in the morning to Ruth at our transition meeting. So we looked at what Frontline had, but we also looked at what people have in terms of best in class around the country for low barrier shelter operations. And we sort of started from there in how we drafted and developed our policy around daily operations.
So would you say that you strengthened the previous policies, or what is your opinion in reviewing the policies that were in place before?
I would say that we strengthened in some areas and changed in others. I think that we really want to go into the shelter from the position of building on what was working, but also redirecting and implementing what was missing. So there's a mixture, a combination of both. Our focus is really on progressive engagement and helping persons who are experiencing homelessness to exit out of the shelter and feel supported in doing that. I think the biggest shift for me is that what we're designing is built around not how to stay in the shelter, but how to leave the shelter. So,
And so you're still under this grant is still under the guise that this is an emergency shelter, correct? So just wondering, I've worked previously at the day center years ago at the homeless shelter, so I know what great work individuals do. I also know how hard it is for some individuals to leave, but I also know that you must have policies in place and you must enforce those policies. If you don't enforce those policies, then you get into some gray areas that is very hard to move a person on that is not quite ready. So just from my point of view, I was just hoping that I could share that your organization would really, whatever policies you put in place to enforce them, and then the individual ladies will conform to that. Not in a mean way or anything like that, but sometimes we have to say what the rules are and to follow them, and that, to me, that helps them gently move on to their next life cycle, because as we move them on, we always have people coming in the door. It's never going to be empty.
absolutely. Thank you.
Any other? Councilwoman Baker and then Miller?
That was my question also. I really would like to have that reinforced. I thought you saying not how to stay, it's how to leave is pretty impactful, but very, very probably multi-factored.
Yes.
So working on job employment, working on the rapid housing, rapid access and housing, all of that is difficult, but it is certainly, I think, an objective that I'm glad to see you focused on. I too would like to see what policies you're going to be presenting tomorrow. Would have been good to have that today, but certainly I'm glad that you are in fact working on those type of issues. That's all I wanted to reinforce your comments.
And our policy analyst, Levine Ross, will be attending that meeting, but, we're getting closer and closer. I mean, we're working, we're getting all the stuff. Eventually, we'll have everything before. I think we're both sides of the coin. We're really working toward that. We're just not quite there yet to have all the pieces in the puzzle before they come to us, but I'm glad you reinforced that. Councilman Miller?
It was my understanding from the Board of Control that the transition contract was going to be only for 2 months. Madam Chair, to the Director, when did the transition contract start? Was it February 1 or March 1?
Through the chair to Councilman Miller, it was February 1. It just came to the Board of Control late. We had initially hoped to provide more time, but it took longer for us to get a signed contract with the Y.
So it's going to be 3 months.
3 months, February, March, April, and start May 1st.
Okay. And second question is if you could please describe what the evaluation process for this contract is going to be and how that's going to factor into future decisions about whether to extend this contract.
Through the chair to Councilman Miller, the actual contract, I believe, includes a description of the monitoring process and what's expected of the YWCA to provide. I don't think I brought that section of the contract, but the Bob Matz Contracting and Monitoring Office staff meet with the agencies prior to starting to do the monitoring, and they go over every element of what's going to be expected. So, for example, with the shelter monitoring, That would include that the facility is in compliance with the City of Cleveland building and housing codes, the fire codes, if food is being served, that the kitchen meets the health department codes, that the shelter is being operated in accordance with the local and state shelter standards, that there's a grievance process in place. There's outcome data that will be looked at, which I referenced in terms of movement out of the shelter, length of stay at the shelter, increases in income when people are leaving. I can send you this, it's quite a long list of items. And we could also share the monitoring template that is developed by Bob's staff. So I think that the feedback from that process then is considered at the end of the year prior to approving additional appropriations for the contract.
So, could you send me the section of the contract on this? And also, since if we were not gonna renew, it would take several months to do a new RFP. Are we gonna have enough time to get this program up and running and evaluate the contract prior to when a decision would have to be made about 2019?
To the chair, to Councilman Miller, I would think that 8 months would be a sufficient amount of time to begin to get a sense of how things are going. I would think that if there were concerns at the end of 8 months, we might do a partial contract for 6 months, and during which time we would then conduct another RFP process.
That makes sense. Thank you.
All right, any other questions? All right. So you're gonna, tomorrow you'll provide the monitoring template as well as we're supplying YWCA with the monitoring template, and they're supplying us with their policies? Is that?
Through the chair, yes. We have a transition plan, and the development of the policies specified by particular area is itemized within the transition plan. So, yes, and that is something that has to be provided before May 1st, obviously, so that we understand what their operational values and practices are going to be.
All right. I take it since it's May 1st, well.
Lots
we
of
should-
time. No,
we can-
joking. We don't have a lot of time.
But we can do 3 readings, and that way we can really take a look at, we'll keep the process moving. It won't stay here, but at least we can see what you guys feel about the policies and things like that when you see it. So I'll make a motion to move R20180064 to council as a whole for second reading. Moved and
Madam Chair.
seconded. All in favor,
Just
say aye.
Before you vote on it, just a comment to that I appreciate all the work that's been done on this, and I'm looking forward to a big improvement, and this is not to disparage the prior provider. They did not have the resources that we're bringing in now, and I'm very hopeful that it's going to make a very positive difference. Thank you.
All right, this item has been moved and seconded. All in favor, say aye.
Aye.
Thank you.
Thank you both. Madam Clerk, if you could read the next item into the record, please.
Resolution number 2018-0065, authorizing Title 4D cooperative agreements with various providers in the total amount not to exceed $11,611,805.77 for child support services for the period 1/1/2018 to December 31st, 2018.
Good afternoon, Council. This is Richard Weiler from the Office of Child Support. These are cooperative agreements between the courts, the prosecutor's office, which is our legal representative in the court, for services related to child support, for the establishment of child support, enforcement of child support. These agreements are necessary in order for child support to recoup federal funds.
All right, any questions in regards to that? These have come before us before. I thought we just had some last year.
Yes, these contracts have to be done on an annual basis. That's a requirement by the state of Ohio.
Okay, but it was the end of last year, I thought.
Yes, there was juvenile court, because of the pay increases, we asked for those two contracts, the juvenile court cashiers and the juvenile court magistrates contracts, to be increased because of the possibility of exceeding the contract amount. If we exceed the contract amount, we cannot get the 66% money back from the federal government for anything above the contract, unless it's amended prior to the end of the year.
Gotcha. Thank you. You were on it. Councilman Miller?
My question is as to why this contract is for the time period starting 1/1/2018, and it's only coming to us now.
There's a long process that's involved. First, we have to wait until the budgets are approved by council, which is not till near the end of December. Then we have to go and get establish the budgets and the contracts with each of the vendors. And then we have to take the contracts, once they're done, get a pre-approval from the state of Ohio, and then submit them into this process. So it takes a number of weeks for each of those things to occur.
And am I correct that this delay does not have any adverse effect on our getting our reimbursement for the full amount?
That is correct. We are asking for this to be approved on second reading. They have to be approved by council and signed by the county executive before March 31st in order to be able to get the reimbursement starting back in January.
Okay.
Okay.
So second reading suspension really is.
That's correct. I'm sorry.
Councilwoman Brown?
Thank you, Madam Chair. The funds come from multiple sources, looks like federal funds, state funds, and that HHS levy. Is the amount exclusive to the HHS levy, or is that for the total, including all the funding sources?
I'm not sure. Can you say that again for me?
So 22.8% looks like it comes from the levy. Is the 11 million relative to the 22% or the entire?
It's only relative to the 11 million.
Okay, thank you.
Any other questions? Pardon us for a minute. Councilwoman Baker?
Yes, just some clarification. Is this a circumstance of coming to us a couple of months late because of the budget approval? And if that's the case, will we always anticipate this coming to us late, or can you remedy having this brought to us before the contract begins?
In the 20 years that I've been doing this, it's come late every time because of the budget process.
If I may follow. And there
Yes,
is
ma'am.
no way that can change. You need more than the time period given after the budget approval to have this.
The only way we could do this is if we knew what the budget was prior to, probably, we would have to know what the budget for the courts and for the prosecutor's office. And each one of these entities has a separate child support index code. We'd have to know that by in October in order to get this into you and approved before January 1st.
Okay, thank you.
And I apologize if the committee doesn't remember, but I remember Director Watkins saying the last time that she was here that due to our budget And so end of the year, that it would always probably cause a conflict with their reimbursement schedule. So if you forgot, I'm aware of that, just needed him to kind of jar our memory and remind us, but we were aware that just can't get around that because we can't change our budget.
The only way we could do it is if we made a contract up based upon last year's expenditures, and then once we knew what the actual new budget was, we would have to go back in and amend the contract, so we would have to come before you twice in each year.
We're not trying to create anything hard for anybody. I think we can survive on these particular contracts like this. Any further questions in terms of this one? All right. And you did say you needed a second reading suspension, correct?
That is correct.
Can I have a motion to move this to the full council for second reading suspension? Is there a second? Moved and seconded. All in favor say aye. Aye. Thank you. Are you presenting the next one? We'll have the item read into the record first.
Resolution number 2018-0066, authorizing Title 4D cooperative agreements with various providers in the total amount not to exceed $107,825.73 for child support services for the period 1/1/2018 to December 31st, 2018.
Again, council, this is our cooperative agreements between the county treasurer's office and the juvenile court treasurer's or cashier's office. This is simply for the collection of cash payments that are due child support. After juvenile court moved to the office of Quincy, we then engaged, this is like going to be the third year that we have a contract with cashier's office for the collection of child support, so we have two different locations. And that was at the request of juvenile court, so that if they ordered somebody to make a payment, that person could go downstairs and make the payment and not have to come all the way downtown to do that. Again, we're asking for suspension.
Second reading suspension? Okay. The two offices that were created are very well utilized, I've heard. People like that convenience, so that's a good thing. We're trying to make everyone's life a little bit more convenient. Any questions in terms of this contract? Is very similar to the other one, other than the two new locations. Hearing none, we can move forward with R20180066 to the full council for second reading suspension. Is there a second? Second. All in favor say aye. Aye. Thank you very much, sir.
Thank you, council.
All right, now we've come to our presentation portion of the agenda, and I was trying to give Ryan White enough time. So who will be presenting? Please come up.
Good afternoon.
Good afternoon.
Excuse me, can you press the button on the microphone? Yes.
It should light up green.
There you go.
All right.
Now you got to say all that again.
I got to say all that again?
Yeah.
All right. I just got my nerves down. So
That's okay.
this is a first for me, so.
That's
All right. My name is Kimberlyn Dennis. I am a 24-year HIV/AIDS survivor. I am also an advocate, a consumer, a speaker, and I've also written a book, Being Positive. And I also sit on the Ryan White board. I'm the only person living with the disease that's one of the Ryan White Planning Council chairpersons. We have two other members that's a Planning Council chair, one from the city and the other one from the county. And the three of us chair the meetings. So the Ryan White Part A program is a equal partner program. A regional HIV planning council for Cuyahoga County Board of Health. And the purpose is to help people like myself in the community to better our needs for HIV/AIDS. Ryan White legislation was a young boy, Ryan White, as you know, may or may not know, a young male, one of the first children of the first. He was a hemophilia who was diagnosed with AIDS at the age of 13 following a blood transfusion in December of 1984. He died in April of 1990, a month before his high school graduation. Ryan White, it's because of him that we have the Ryan White Care Act, the first it was first enacted in law on August 18, 1990 as the Ryan White Comprehensive AIDS Resource Emergency Care Act, which is the CARE Act, amending and reauthorizing 4 times prior in 1996, 2000, 2006, and 2009. We're the largest federal government program specifically diagnosed to provide services for people living with HIV/AIDS, PLWAs, which is persons living with HIV/AIDS. We use a lot of acronyms at Planning Council, so forgive me. August 18, 2016 marks the 25th anniversary of the AIDS Care Act. The purpose for the legislation is to address the unmet care and treatment needs of persons living with HIV/AIDS who are uninsured and underinsured by funding primarily health care and essential support services that enhances access to the retention in care. We no longer have the emergency relief. It's no longer emergency relief for overburdened healthcare systems. It's no longer a problem for providing life-saving care for those living with the HIV/AIDS. The Planning Council representative reflectiveness. The reflectiveness consists of the race, ethnicities, the people living with HIV/AIDS, the total number of Planning Council members, and we do a process PSRA, which is a process resource allocation, which we're in the process of doing now. The membership must include specific legislative categories. It must include the 33% consumers who are not affected with HIV/AIDS, are not afflicted with HIV/AIDS, non-service providers. The overall membership is PLWA members who must reflect of the epidemic of the TGA with particular considerations given to disproportionate, effective, and historical underserved groups and subpopulations. The emphasis on the race ethnicities are the genders, the race, genders, and age. And we have people that's living with the disease, the white non-Hispanics on the board, which is number 1,785, which is a percentage of 32.88%, which is a number of 9. We are serving 40.9%, which is a number of 1 on our Planning Council board. Blacks, non-Hispanics is 11, which is a 50%. And then we have the multi-race, which is 1%. And then we have, which equals all a total of 22%. So we in compliance with our reflectiveness. The grantee and Planning Council roles and responsibilities are for the Planning Council. We form membership operations. We have needs assessments. We have comprehensive planning. We do the priority setting resource allocations, which, like I said, we're working on now, where we put together, we rank the priority settings, then we put the categories in order, and then we put the dollars with the categories. So we made it into a 2-day process because it's overwhelming once we rank the categories and put them in order to put the dollars with the categories. So we needed to regroup and come back to work with the dollars. So we made it into a two-day process, and we're working on that as of June of this year to get ready for the new grant year come after July. We also do directives. We coordinate coordination of services. We do system of care, and we do contracting pro-current contracting. No, that's not ours. We do system of care, and we do assistance of the administrative mechanism. The Planning Council's responsibilities is to develop and implement policies and procedures for Planning Council's operations, assist in community needs, and the community needs most of the time is done through the work from the Community Liaison Committee. The committee structure is the Community Liaison Committee, which is a committee that's with all people living with HIV/AIDS. And that committee does community forums. That community we're working on now, we do community forums. We also help with the PSRA. We hold, we hold events, and we give input back to Planning Council as people living with the disease, what their most met needs are in the community as a person living with the disease. So that's the Community Liaison Committee. The Strategy and Finance Committee works on training strategy and finance members, recruiting people, getting more people to get involved in the community, doing the assistance of the Planning Council, reallocation strategies, review and approve carryover requests. When we have a carryover request, the membership retention and marketing membership does the finalization of nominations of the policy, review and finalize attending policies, conduct biannual Planning Council membership for the federal reflective mandates, develop and implement a comprehensive planning council training program in accordance to the HRSA cap. So our community meetings, Consumer Liaison Committee, Strategy and Finance, and Membership Retention and Marketing meets every second Wednesday of the month. And the Quality Improvement and the Executive Committee and Full Planning Council meet every third Wednesday of the month, which those three meetings take place today. The quality is at 3, and then following that goes the Executive and Full Planning Council. The Executive Committee consists of all the chairs and co-chairs for each subcommittee. And myself and the other two co-chairs for Planning Council, we designate who will be the chair and co-chair for each committee. And each co-chair and chair comes to the Executive Committee to give the report on their committee and give the update. And then after the Executive Committee, we have the Full Planning Council Committee, the overall committee. So any work that's done in Executive Committee, we vote on it, and then we move it over to the Full Planning Council Committee. If there's anything money that we need to make a vote on, or any order of business that we need to vote on, all that takes place in the Executive Committee. The service ranking categories, like I said, we have core services and we have support services. This is our PS priority setting recess allocation form. We rank them the most needs to the least most needs in order. And then once we rank them by the categories. Then once we do the categories, then that's when we go ahead and we reallocate the requested dollars for each category. And then we put the percentages, we allocate the percentages after that. So we do that in the month of June of every month. We meet every month, like I said, the second Wednesday, the subcommittees, and then the third Wednesday, the Executive Planning Council. The only months we do not meet is July and December, but if there's an order of business that has to be done or something needs to take place, we do have a meeting, or we do the order of business in July and December. So, but usually July and December is the only 2 months that we do not have any order of business. We were doing PSRA in July. We moved it to June this year because of the new grant year. The new grant has to be worked on, the information has to be worked on. And plus, we also working with the consumers and the Community Liaison Committee, working with the small groups, gathering the information for what are the most important needs in the community of people living with HIV/AIDS, getting the most met needs on what their needs are. And so I always express to them and stress to them, being a person living with the disease, I know what my needs are, but I don't know what someone else's needs are. So we need to hear from the community as to what their needs are. And then we bring all the information back to Planning Council and we compile it, and that's how we rank the categories on what's the most met needs and what's the least met needs in the community. So it's a lot of work that needs to be done and gets done. And we have a PCAT, which is our Planning Council activity timeline. So each month we're constantly doing something each month and making sure that the order of business is taking place and recruiting people to be a part of Planning Council, the importance of being part of Planning Council and of getting involved. And this is my purpose in being involved, like I said, being a long-term survivor and also an advocate and a speaker in the community here in Cuyahoga County. The epidemic profile. The epidemic profile consists of, in 2015, a TGA, which is Cuyahoga County, Lake, Ashtabula, Geauga, Lorain, and Medina counties, which is 5,243 people. 2015 also consists of a Cuyahoga County, 4,512 people, which is an 86% total. And it also in 2015, Cleveland equal 3,496, which is a 77% total of Cuyahoga County. So we are a TGA. The TGA, let me see.
So I just want to interject and ask a question. So that 77% is out of Cleveland residents.
Yes.
Makes up that number, 86%.
Yes.
Okay.
Yes, Madam Chair, yes. So, gonna give it to the grantee reporter.
Madam Chair, Melissa Rodrigo from the Cuyahoga County Board of Health. I'm the supervisor of the Ryan White Part A program. In essence, my team makes sure that we keep compliance to the grant and try to complement Planning Council's good work. I think Kimberlyn undersold how much volunteer time that our Planning Council members put in to these efforts. She mentioned, the 2 days a week, 2 days a month that they put forth, but there's also numerous calls with our federal provider that she partakes with, also with the other co-chairs and participation of collaborating to ensure that our agendas are where they need to be monthly. And we're addressing the order of business, so we are staying compliant with our federal requirements. So those funding continues to come to our transitional grant area. The transitional grant area, it encompasses 6 counties. It's not just Cuyahoga County. So it's Cuyahoga, as you can see, Kimberlyn talked about the epidemic profile. The majority of the clients do reside in Cuyahoga County, but we also serve Lorain and Medina, and then also Lake, Geauga, and Ashtabula. We have numerous providers of services. So we fund 18 different service categories, and we have 13 different service providers that can provide a number of the service categories. So you're going to see that in that chart that was provided to you. So some of our larger providers are the county hospitals, so Metro Health, but also university hospitals. And then we also have a medical provider out in the eastern counties. So we have Signature Health, and then to the western counties, we have Mercy Health. Those are our main medical institutions. And then we have a smaller medical institution as well, the AIDS Healthcare Foundation. So our main focus is obviously ensuring clients have access to healthcare, but then we also coordinate the 17 other categories to make sure that clients have access to additional resources that they might need. And that might be medical case management to medical transportation, to oral health services, to mental health services, a dietitian to address needs, support groups, substance abuse, and housing case management would be another one. One more. Yeah. So we also provided for you, just based on the 3,093 clients that were served last year in the 2017 year, just a variety of different charts to just show you the various clients that were served within the 6-county area. So residency, obviously the 88% that's in Cuyahoga County, you can see only 7% in Lorraine, 2% in Ashtabula, and 3% in Lake County. And these are clients that the Part A funds paid for at least one service. It doesn't mean that the clients, every client doesn't need Part A services. Obviously, if they have private insurance, it would not touch our funding. The various age groups, 51% are between the ages of 45 and 65. And all this kind of fits into that epidemic profile. If you look at the complexities and the stats of the disease, we serve roughly what the epidemic profile reflects. Race, 61% African American, 38% white, and 1% other. 90% are non-Hispanic, where 10% are Hispanic or Latino. For our gender, 23% are female, 75% are male, and 2% are transgender. Most of our clients are below 100% of the federal poverty level. Also, the majority of our clients, well, 48% do access Medicaid. Risk factors, 37% are heterosexual, 55% are men that have sex with men, and 5% have identified as IDU. Housing status, 85% have.
Madam Chair,
Yes.
what is IDU?
Can you please just explain what IDU is?
Drug
for
use.
us? Drug use. Thank you.
Oh, intravenous drug use, okay.
85% have identified that they are stably housed, where 9% have identified that they are unstable, and 6% just did not report. The next chart is just a sampling of, the next two charts are the sampling of the 18 services that are provided by the Part A program, and the number of unduplicated clients that are served within those service categories. Every service category has a standard of care that the funded provider must adhere to ensure that clients are provided high-quality services. A large part of our program focuses on viral load suppression. Of the 3,093 clients, we paid for a medical visit for 2,023 of those clients, so we have medical data on those clients. Of that, we have identified that 85% of those clients are virally suppressed, and I think you received from a previous presentation that if a client is virally suppressed, there is a very, very, very slim chance that HIV will be spread. And that's what we want. We want viral load suppression to just overall improve the health of the community. We do focus on disparities. We align with our national partners as to looking at targeted populations. So the 4 focus groups that have been selected, but which have been identified nationally, are men that have sex with men of color, African American and Latino women, youth, and transgender people. We have all of our providers have identified clinical quality improvement projects in which they follow cohorts of clients that are not virally suppressed and give them extra care, extra support to try to get those clients virally suppressed. Last year, we saw an 8% improvement based on those cohorts. You can also see why we selected those disparate populations based on these facts, which are quite staggering.
What'd you say MSM of color stands for?
Men that have sex with
Okay,
men.
okay.
Of our clinical quality improvement projects, there are a variety of different approaches that our providers take to try to reach viral suppression with some clients. Depending on what type of service provider they are, if it's a medical provider, you might see frequent huddles based on a multitude or a team approach. So it might be the ID doc coupled with the nurse and the medical case manager to talk about a client's needs and address the needs to ultimately improve or suppress that client's viral load. And it might just be also just frequent telephone calls, reminders, even appointment today. Some folks are really trying to improve their no-show rate to ensure that clients are getting the medical care that they need. This is just a chart for you. So we obviously we take into large consideration what our viral load suppression rates are. And this is just a snapshot of what our 2017 viral load suppression rates are. And that concludes our presentation.
So some of your statistic on the clinical quality management, why is it determined that Black women are 20 times more likely to have HIV than white women?
That's a federal research.
Is that due to prison stats, possibly?
The women?
No, that African-American male counterparts are more likely to be in prison, and when they come out, I don't know, I'm just wondering what they...
No, it's just based on the, so what happens is that if a client tests positive, it goes into a state database, which ultimately gets funneled up to the Center for Disease Control, which looks at all the stats, and then they release, basically, they tell us what the stats are and who is more likely to contract HIV. So that's what these stats come from.
I wonder what they base it on, though.
Reporting. So when a person tests positive,
Okay, I got you.
it's
I got
identified.
you. All right. Any questions from the committee? Councilwoman Brown on point of my question, and then Miller.
Thank you, Madam Chair. Relative to what Councilwoman Conway was saying, because it seems that men who have sex with men, it's 46 times higher. So are the statistics reported from men who are in prison?
Yes, anybody that tests positive gets rolled up into the state. The state collects the data, so mandatory reporting of positive tests, and then ultimately they duplicate clients nationwide.
Okay, and so I guess, and I'm not trying to speak for you, but I'm thinking that maybe that has there been any research or correlation relative to the population and how it has upon their reentry impacting the African American women in the community? Is there a higher rate of that in African American male that are, or even men in general that are in prison that are being reintroduced into society that are increasing the numbers relative to our community?
So I don't have those stats. I can tell you that we look at the epidemic profile annually. We usually don't see very many blips in data. Last year we did see a little bit of a higher increase in African American women that we haven't seen in the past. And then we don't do the prevention part, but we rely on our counterparts at the City of Cleveland that receive the prevention dollars to do targeted testing and education in the communities that might be greatly impacted.
Okay, thank you.
And just on another note, we're very limited as to what we can do, if anything, in the jails. Because there are additional federal dollars that are identified for those purposes. So they really restrict us. Unless a client has a release date, we really can't do much.
Councilman Miller?
I have a question on the resource allocation. Transportation assistance was rated as the second highest of all the priorities, but it only got 95,000. Why is that?
So that's actually a category that Planning Council, over the years, has put a significant amount. I would say they doubled the amount of resources in that category. There's a multitude of ways a client might receive transportation depending on where they reside. With the medical case managers and the housing coordinators, they try to work with clients so they could, if they do not have transportation, find a safe residence where they might be on a bus route, and then we're able to provide bus tickets to those clients to get to any and all appointments that they might need related to their HIV status. If they do have a car, we provide gas cards if they're in an area that might not have that transportation, or if they do not have a car, like in our outer counties, we provide a lot of resources towards taxis, as they are quite expensive. We've probably doubled the amount of clients that have touched or received a service in medical transportation, but it's always a gap. And we do rely on our medical case managers to ensure that clients know that they can take advantage of that service. And I would defer to maybe Kimberly as to see her thoughts, as having been on Planning Council for a while, to see her thoughts on medical transportation.
Well, I do know medical transportation is a barrier because people won't go to their appointments or go see the doctor if they don't have the transportation to get there. And not only that, the transportation, like she said, everyone doesn't have maybe a car, but they may be on the bus line where they can get bus tickets to get transportation. And then in the rural areas, the people out there have to travel so far, so they have to use other means for transportation. Transportation, like she said, is one of the main conversations that always comes up in every committee meeting. Because the goal is to get people into care and to keep them into care. So if we're trying to keep people into care, a lot of times it's the transportation that's causing them to not stay into care.
On just one additional note, I can tell you any of our providers that requested transportation dollars, we provided them every dollar that they were requested in that service category.
Has the drug cost came down since Ryan White legislation was implemented? The cost for the drugs, it's the same as in the 80s when it?
The drug costs, because I get my medicine through Ryan White, the cost has not come down, but providing different CVS places for us to get our medications has been changed, where we were getting it out of Pennsylvania, out of CVS Caremark, and now we can go to any CVS to get our medications, and that comes from Part B, the ADAP program from Part B.
The cost hasn't come down
But
at
the
all.
cost has not come down at all.
It's very expensive. So the state receives the majority of, it's called Part B funding. It's basically a state appropriation. And the main appropriation is to cover pharmaceuticals for any client within the state of Ohio that's below 300% of poverty. Obviously, you can identify if you're paying $3,000 a month for pharmaceuticals. Even if you are above 300% of poverty, that could be quite impactful. You might not have funds for anything else. In this area, we pay for health insurance and health insurance premiums for clients that are 301 to 500% of poverty. So clients within our grant area do receive more benefits than clients in the remaining part of the state.
Any advocacy to get costs down from your planning council? Any advocacy that you guys are doing?
We're really limited as to what advocacy we can do with Planning Council. The feds restrict it, but on their own, I know Planning Council has tried to work with some of the pharmaceutical companies.
Okay. I had another one, I don't know what I did with it. Well, oh, sorry.
Yep, I had
Councilman
a
Howard.
quick question. I see that young people are 5 times more likely to have HIV than people older than 25. I was just wondering, what strategies do you see as effective for engaging young people and teens to maybe stop with the transmitting of this disease?
Advocacy and speaking. I do a lot of education in the community, but trying to get into the education to schools. They're trying to stop the education for this information to be brought into the schools. I know the importance of it because I do it on a daily basis. I have a nonprofit organization, Ministry of Hope, and I'm contracted with Beachbrook, and we go in and we do education, but they're trying to stop those grants has been taken. So it's limited education, but the numbers of the youth are steady rising. And the reason why I know that is because a lot of them I advocate for and I counsel and speak, do one-on-one education with, because they're young and they don't know anything about the Ryan White system, and they also is afraid to disclose. We're still dealing with disclosure issues and ignorance of this disease in the community. So it's a fight and a battle, but it's one that's needed. But when you have things taken away, that's important. As far as education is the key. To give to the youth. They don't have that education. It's hard to give them keep them engaged in how to sustain.
Just a follow-up question. Is that the issue, the bigger issue as a whole, just the disclosure or the educate? What's the biggest issue you guys find when trying to educate people on this disease?
Disclosure, as well as the ignorance of the disease, the education of knowing about the disease. It's sad to say that people still believe that if you touch a person or kiss a person or hug a person, you can contract HIV, and that's no way you can get it. So the disclosure, and then, like I said, educating them on the disease, and not only just the disease, on the importance of staying abstinence, and why it's important to stay abstinence. But a lot of our youth are not abstinence. And so we can't give them half the package. And so when I go out and speak, I have to give them the whole entire package, on how to protect themselves. They're afraid to ask questions. They're afraid to engage in questions, especially with someone that they don't know if they're going to be discriminated from or for. So I have to continue to impact that disclosure piece with a lot of people that I come in contact with. Keeping that confidentiality and to be able to assist and help that person to engage them the proper information, to get them the knowledge of Ryan White, the importance of Ryan White, the story of Ryan White, and also to help assist them the importance of going to the doctor, taking their medications and staying in treatment and getting medication, getting their medications. This is a passion for me, especially as a person that live with the disease, and that's what my book is for. It's really been in helping, engaging, and impacting the community here in Cleveland to help people to know that they're not alone, and especially to the youth as well, that they're not alone. So,
Thank you for the work.
Thank you.
Councilwoman Baker.
Thank you, and thank you for your work. Since Ryan White was diagnosed with the blood transfusion, has there been significant improvement in blood transfusions?
Yes, there has been a significant improvement in blood transfusion. Now, it's hard for a person to contract HIV/AIDS through a blood transfusion because the blood is tested now. And if a person is diagnosed with the disease, that blood is not used. So like back in the day, people were getting diagnosed with blood transfusion, but now that's not the case with blood transfusions.
So are you comfortable in saying then that the blood transfusions that of his day Are they completely eradicated, or is there still a chance, or how comfortable are people when they think of blood transfusions and the need of having one, and what you have gone through since this conception?
I know nothing is 100%. So, but I do know that the Red Cross and people that does the blood drives do a wonderful job in testing the blood to make sure that the blood is clean, it is not contaminated with any other virus. And so I would say 99.9%.
Good. Thank you very much.
The
Yes.
regulations based on the labs are pretty extensive.
Yeah, good. Thank you.
I think that also includes, like she said, other diseases as well. So
Yes, other
it's not
diseases as
just AIDS come from it,
Exactly.
cancer and all that. So we have pretty good blood out there. Any other questions of these ladies? I just had one final. I know in your statistics about the young people are 5 times. Well, in that category, in that slide, I noticed you didn't mention Latino women. Are they considered in the Black woman count?
So they're not nationally. That's just more of a local stat here based on our FB profile.
Okay. All right. Thank you.
Thank you.
Thank you.
Thank you both very much for your time, your work, your dedication.
Thank you.
Thank you.
Is there any other matters that need to come before this committee? Any miscellaneous business? Any other public comment?
Yes, Reverend Pinckney?
For anybody that's just beginning to watch, I'm Reverend Pamela and Pinckney Butts. I'll be glad when all this mess is over with, for real. Councilwoman Conwell. Before I go to the non-agenda, I wanted to tell you that Department of Children and Family Services stood before you and did not tell you the truth. And I'm a living witness of that. I fell through the cracks of the system. And I just want to cry sometimes. Because I sit here and I listen to them lie and dodge my phone calls. And I lost my children because of them. And now my grandchildren. And I'm watching my life pass by me. I want you to do a formal investigation against them, please. I'm suing them and the Cleveland Police Department. Mr. James McCafferty started this mess when I challenged him when he was the director of the Department of Children and Family Services. And he and some other legislators and some other leaders spread rumors about me around this country. And now I have no safe place to live. I've made multiple efforts to meet with Mr. Math, Cynthia Wise Kittle, and others to clear this up. And now I currently have no rights to my grandchildren. And I was asked recently, since we wouldn't give you anything for your grandchildren, how did you get it? As if I'm some type of criminal. I'm a multiracial, heterosexual female. And I went from riches to rags for reporting abuse. Well, these people have the nerve to sneer at me and turn noses up at me. I went into the homeless shelter to avoid a situation in my home because they put drugs in my children after being told that they did not need them and turned my children against me. These are the documents of my suing the state of Ohio, Indianapolis, and the state of Indiana as a result of the Department of Health and Human Services in the United States of America. I just had an occasion to celebrate St. Patrick's Day because I am a My great-great-grandfather is Mitchell Graham, was Mitchell Graham, who was an Irish soldier. And it's unfortunate that we still are dealing with racism and sexism. Thank you. And the defendants who are eliminated are aware of who they are in these lawsuits.
Ms. Lou? Ms. Lou?
I thought you left, Miss Lou. I apologize.
I'm only short. Good afternoon again. In response, I will make that clear, I'm only short. There were people leaving council's chamber, but unfortunately, not me with my short legs. So not yet. Actually, the person left, the lady from YWCA, I really wish she could have stayed here. I did come to county council meeting not too long ago, and I said, attending the Homeless Congress, I found out YWCA did not know anything really they need to know about the true conditions right now, currently still on at this place. Unfortunately, she already left, so she would not really hear me first ear, put it that way. The current situation has been this. Basically, this shelter became a psych ward outside of the hospital. Through central intake system, majority of the people coming into shelters are emotionally, psychologically, mentally unstable. Sure, we also have financially unstable and job unstable and all others. One thing I know for sure, for domestic violence houses, when they put a plan for their residents to exit, sometimes they have to exit out to another state. So when Ms. Baker said they will focus on exiting rather than staying, it's very impactful, yes. Please pay attention to this whole situation because none of you have ever been really homeless yourself. The current situation is our community, also the whole country, there's an affordable housing crisis because there's almost none. So if you want people to exit from shelters, homeless shelter, doesn't matter emergency category or not, where would they exit to? If they do have a places they can exit to keep them safe and they can hold on to the housing, of course, problem solved. However, at least in the 5 or 6 years, it has not been the situation. Right now, you even have more people coming to shelter with the same trades. Majority of the people in the shelter right now, they have no way to hold on housing. I came to county council meeting, I wish the new service provider can happen and can have a little more money because I was in hope that this new service provider will help to heal the traumas and to help people at least to get a temporary peace in order to prepare themselves later to be able to hold on housing. But now, it seems like a data performance score will still win over real human lives. So please pay attention. The current policies by the current service providers, everything is for management's convenience. Everything actually defeats the purpose to help homeless people, for them to get on with their lives, no matter they need a shorter time or longer time. Please pay attention to those policies. Lots of them, what you see on the paper and what it actually shows in reality, and to create more traumas on people, you don't see it yet. But of course, I'll be coming back to let you know, to give you the thorough update. Thank you.
Madam Clerk, is there anyone else?
No one else is signed in.
All right, thank you. Meeting adjourned.